Really?
Good evening, everyone. Welcome to iFocus Online, Lecture 208 and Retina Session 60. And this is the masterclass by Dr. Shrinivas Joshi, sir. And he'll be talking on artificial retina and new frontiers. And as this is the last teaching lecture or the educational lecture, as I may put, of the retina session, I will really thank the whole retina team for being there. We do have the 3 more lectures coming up. So I request Dr. Lalit sir to please introduce Dr. Shrinivas Joshi.
Shrinivas Joshi is a young surgeon, actually, compared to, because he hardly has any gray hair compared to all my gray hairs. But in this, short span, he has blossomed like anything. Must say for last nearly a decade now that I know him, and he has been part of, all AIOS conference, retina sessions every time. The reason when I spotted him, doing great work when he was in US, so I had heard him, then I offered him, you please come down and deliver this guest lecture. Honestly speaking, I didn't know. I was not very friendly with him at that time. It was mere Santosh because of his achievements at that time. I, offered him that honor. But that was such a nice experience for the entire country, India, that here was a man, Indian man, doing fantastic work in US and came as a guest for AIUS. You see, he is one of the finest VR surgeons India has, and one of the first to start, heads-up surgery. I remember visiting Joshi Institute. All of you know that Ingenuity machine by Alcon. He was one of the first to acquire that machine. And I remember I was operating in one of the theaters and he was operating the other theater. And this fellow will do so many cases on Ingenuity. And I know he has now become addicted to Ingenuity machine. And now he does not do routine microscopy surgery. He does only heads-up surgery. And I think in India, he has one of the maximum experience on Ingenuity. And the only one in India who has first-hand experience in artificial retina. I do not think anybody in India I can remember or I know of who knows so much about artificial retina as Shrinivas. So I think congratulations to Santosh who picked him up for this very important topic of artificial retina. And today, believe me, artificial retina, I remember way back, 9-10 years back, US FDA even granted approval to Argus 2 processes. And there was a huge media coverage. And today we'll hear Shrinivas and come to know what exactly is the status. And the list of achievements you can see here. You see, no, I do not know who has won this Red Buckler Award so many times. Recipient of Senior Honor Award by ASRS. He's junior, but he still has Senior Recipient Award winning by ASRS. So hats off to you, Shrinivas. And on behalf of the entire iFocus team, we welcome you to this very interesting talk. I'm sure this will excite a lot of interest and questions amongst our audience. Thank you, Shrinivas, for accepting this. And you can start sharing.
Thank you, sir, Lalit, sir, for those kind words. And I don't know whether I deserve all the words you have said. And thank you, Santosh, sir, for this wonderful opportunity. And you people watching it itself and selecting me itself is a great honor for me. Thank you very much. Thank you, Ronika. Thank you, Shefali. So I'll be just starting my presentation. Hope my screen is visible.
Yeah.
Yes.
Yeah.
Okay. So
We can just click on it once.
this is better. Thank you once again. So today I'll be taking the topic on artificial retina, the concepts, evolution, and what are the new frontiers. So to as much I can, I had my experience and what knowledge I had about this and what I have been reading literature about this, I had tried to gather all these things and try to make a collective presentation. I have absolutely no financial interest in this presentation. So we all know that the optic nerve, the retinal prosthesis, especially a type of bionic eye. Bionic eye is nothing but is called as the bioelectronic eye. These are implantable electronic devices designed to stimulate the sensation of vision in the eyes of an individual, especially when the patients are suffering from retinitis pigmentosa or age-related macular degeneration, where the optic nerve and visual cortex, I repeat again, the optic nerve and the visual cortex has to be intact. So in 2003, the Argus 2 became the first retinal prosthetic device to be approved by US FDA for the late-stage retinitis pigmentosa. So we all know that the visual prosthesis may conceivably be developed for any part of the visual pathway, including the visual cortex itself. But the retina is considered to be an easiest target for the outer retinal disease. The reason, because of its easy accessibility and partially intact neuronal architecture. So the designs for the retinal prosthesis are generally categorized where they are, whether it's on the surface of the retina or inside the surface of the retina. So it's basically divided either micro photodiode arrays or the micro electrode arrays. So the micro photodiodes, they generate the electric current from the light entering the eye, while the latter depends on the camera based. So I'll be coming to the various examples of these. So it has a camera, processing unit, a transformer, which converts the light from the images to the impulses. So how it happens through the chemical reactions, I'll be coming into it. So the advantage of the micro photodiode array include having no need for an external camera or processors or whatever you want to have these devices. But the micro electrode array, on the other hand, they are filled with too many kinds of things, like you have the camera, you have the prosthesis, the electronic coil, you have a video processing unit in your pocket, a battery, and all those things. The advantages is it has it can enhance the contrast, edges, and the other features of the visual field. So as I said, they are if they are implanted on the surface of the retina, they are called as epiretinal. If they are implanted inside, then they are subretinal. So the epiretinal designs benefit from being easier, less risky to implant, whereas the subretinal designs may benefit by utilizing the intact middle layer because they are inside the layers of the retina. So they are more closer to the middle layer where the conduction of the impulse is easier, formation where it transmits to the amacrine, horizontal, or the bipolar cells. So this is how it looks, the first US FDA approved bionic eye. So before that, let us look into the little bit of history. The implants first retinal process began in 2002, and 9 years later, the Argus 2 was developed after doing a clinical trial of 30 patients. And then 2 years thereafter, in 2013, the Argus 2 became the first retinal prosthetic device, and it is estimated that, well, over more than $100 million has been spent by the sponsors. Almost 20 years of the dedicated research being done by these researchers for development of various retinal prosthetic devices in US, UK, Germany, Japan, Korea, Australia, and China. So the Argus 2 is developed by a company called a Second Sight Medical Products Incorporation, California. So first, let us see how the vision is conducted. It's very important. So that we all know that the principal signaling pathway, the most important are the photoreceptor cells, right? So the photoreceptor cells are nothing but capture the incident light. They amplify and sends it to the horizontal cells, which helps in noise reduction and adaptation, and then to the bipolar cells, which connects the impulse from the photoreceptors, pass through the bipolar cells, and then it transmits to the ganglion cells. So in the bipolar cells, we also have the nearby, we have the amacrine cells, which enhance in spatial processing. So ganglion cell, it collect all these signals and compare the B signals by the bipolar cells, and finally it sends the signals to the brain. So how does the actual the vision happen? How the process is happening? we all know that the photoreceptors form the specialized class of the retinal cells. So these are nothing but the cone cells, which we all know is helpful in the daylight, and the rods, especially in the dim light or the night vision. This cone pedicle, which I'm telling about, cone pedicle contains the synapses. So that releases the neurotransmitter molecules in response to the light-induced changes in the outer segment. So now, how these artificial retina are based on that, you need to stimulate these neurotransmitters, and how artificially you can excite a neuron so that the impulse is generated. So these basically implants are for the patients who are blind from outer retinal degeneration. So this is the schematic representation which I was telling. If it is placed on the surface, it's called as the epiretinal. If it is placed inside in the neurosensory part, it is called as the subretinal implant. So this is the pictorial form. If you can see the ultrastructure evidence of the donor RP and AMD, this is how the normal it looks like. But in case of RP and AMD, this is how the extensive rewiring happening. So because of which, what happens, the impulses are not conducted properly. And in some cases, the glial cells migrate into the choroid. So these preclude the high spatial resolution in retinal interface. So we all know, I'll not go into the details of the retinitis pigmentosa. It's an inherited disease. And also this has been tried in the macular degeneration, which I'll be coming it a little later. So how does the RP blindness progress? Generally it is night vision loss by age 20 is called as stage 1. Peripheral vision loss by age 30 is stage 2. Legal blindness by age 40 is stage 3, and complete blindness, we call it as stage 4. So there are various research therapeutic strategies like repairing the gene, slowing the disease, regenerate the photoreceptors, make other cell perceive the light. However, the easiest one which they have found out is bypassing the retina, which I'll be describing about. So this is the case of, you can see for the interest of the postgraduates, you can see this is the waxy pallor of the disc. There is an arteriolar attenuation here. You can see this extensive bony spicules. There's a macular atrophy. So this is nothing but the late stage of the retinitis pigmentosa. And these are the candidates who are very ideal for the retinal prosthesis. So it all started in 1998 that demonstrated that a blind person could be made to see the light by stimulating the nerve ganglia behind the retina. And this proved that the nerves behind the retina still function even though the retina had degenerated. So this gave the information like how not we could find out a device and try to stimulate these remainal neuronal cells so that the electric impulses in turn generate the neuronal impulses which transmits to the brain and the image gets percepted. So the Mark Humayun is the father of the Argus implant. Himself is involved with the research on the second site, Argus 2. So indications, basically adults age 25 years or older, severe profound outer retinal degeneration. And as I said, the light perception has to be there. And the visual, the optic nerve and the visual cortex has to be intact. And the patient needs to have some previous history of useful vision. So let us see how this artificial retinal prosthesis look like. Sorry. Yeah.
In Second Sight's Argus 2 retinal prosthesis system, a miniature video camera in the eyeglasses captures a scene. The video is processed by a small portable unit and transformed into instructions which are sent back to the glasses. These instructions are then transmitted wirelessly to the implant on the eye. The implant consists of a receiver and an array of electrodes. Instructions are received and corresponding signals sent to the array, which emit small pulses of electricity. These pulses stimulate the retina's remaining cells and are transmitted down the optic nerve, conveying visual information to the brain, which perceives patterns of light. Patients learn to interpret these visual patterns.
So this is how the animated video about how it works. So the indications I have already spoken about it. I'll not go much into the detail of it. Now, how the external part. So as I said, it's the camera, that's the Oakley glass, which has a miniature camera. This is the electromagnetic coil and the video processing unit, which is placed inside the pocket. And this is the internal part, which is the electronic case, which sits on the supratemporal part of the sclera, and the incision is made where it passes on to the vitreous cavity, and this 60 microelectrode is made to sit on the posterior pole. So now let us understand how these artificial retina actually generate vision. So we all know that some of the ionic channels open or close depending on the voltage gradient across the membrane. So these ionic channels allow the flow of the ions across the membrane, and because of the influx of the sodium inside the ion and from the resting membrane potential, it reaches to plus 40. That is how the action potential is generated. So let us see this. So as you see, the internal of the cell is highly negative. That is, you can see the resting potential inside the neuron is around minus 70 millivolt. And from there, so now we need to stimulate this. So somehow this opens the sodium gated channel so that the sodium enters into the cell. And as it reaches the refractory state, say around plus 40, and then the potassium continues to leave the cell. So this is how the action potential is generated. So from minus 70, when it reaches to plus 40, the action potential is generated. So the impulse is generated so that it can be conducted through the ganglion cell, optic nerve, and then to the brain. So this, if you can see, when the light is passed on, so there is an inactive opsin, which becomes an active opsin, right? So for this active opsin to get further converted, so it needs the photodiesterase. So from GTP, if you remember a little bit about the biochemistry, what happens in the physiology of the vision? From the GTP happens CGMP. From the CGMP, you have GMP. So from the GTP to CGMP, you need that is called as the guanylate cyclase. So CGMP is very important because it regulates, it controls the opening and the closing of these ionic channels. So this is how the normal vision happens. So now what we do, this electric field, where we put this electrode on the retina, we stimulate this electrodes. So the electric field which is generated, that alters the extracellular ionic concentration near the electrode, and because of which there will be an opening of these ion gated channels. So this is developed a little complex through the Hodgkin-Huxley model. I'll not go into the detail, but the model initially included just sodium and potassium and the leakage current, but later on it has been expanded to include a variety of other channels found in the mammalian neurons. So the conductance of each channel is controlled by its gating variables, and each gating variables is controlled by the voltage across the membrane. So normally a neuron achieves action potential by integrating the synaptic currents over the time. So these synaptic currents, they change the potential across the membrane. And because of that change, that is what I explained, influx of the sodium from minus 70 where it is to plus 40, that trigger the depolarization, which opens up the sodium gated channels. So these extracellular stimulation, what we give through these artificial retinal prostheses, they stimulate, they generate an electric field around this electrode, say Argus 2, which has around 60. So each electrode, they generate an electric field around these neurons. So because this electric field alters the extracellular ionic concentration near the electrode, that helps in opening up of these ion gated channel. This potential change can initiate an action potentials also in the nearby neurons. So this, I'll be showing few videos which we did it in Toronto Western Hospital, and the surgery took around 4 hours, minimum around 4 hours, and I'll be showing straight away the video rather than the steps. So this, you can see the video here. So now we do a complete 360-degree peritomy as we do in any scleral buckling procedure, hooking the muscles. And then we place this external coil. There's the electromagnetic coil. We place it on the supratemporal aspect of the sclera. And then this has this similar what we use the 240 band, and it is tied with a Wattskate sleeve. So this is now sutured. We need to fixate it on the supratemporal part because it should not move. So here we have the suture fixation tabs through which we try to suture it. Now comes the most important part, is this 60 microelectrode array. So before we do that, we have to do a vitrectomy. So here, Dr. Robert Devaney, who performed this surgery, one of my mentor, now he's using an external light illumination, that's the chandelier illumination. And doing a vitrectomy is very, very important, inducing a PVD. If there is any epiretinal membrane, that has to be removed, because this might cause the alteration or the change in the placement of this artificial retina. So slowly a PVD is induced, and then need to take an MVR blade. So we are making an incision of around 4.5 to 5 mm. And if you see this forceps, these are not just metal forceps, but the silicon tipped forceps, because any metal forceps can damage this electronic circuit. So slowly we try to implant this. All care has to be taken not to expose it suddenly, because it can happen. The suprachoroidal hemorrhages can happen because it's a pretty large wound, and snugly trying to push it inside into the vitreous cavity and slowly try to bring it down. We should take all the care that there should not be any twist in the cable. Otherwise, the whole surgery has to be repeated. And there are a set of around 5 to 6 engineers behind around us who will be telling us whether the implant is working or not. So that is very important, because at the end of the surgery, if we see that the implant is not working, then the whole surgery is futile. So after some time, they they tell us to stop the surgery, and they check how the implant, how this implant is working. And now you can see here, we place it diagonally on the posterior pole. Now, how to fix it on the retina? So these are nothing but, we call it as 19 gauge screws. That is nothing but the tacks. So here you can see we are just taking the tacks and making a 19 gauge entry through another port. And with the help of the extrusion cannula, we try to balance it, and then we try to fix it in that screw where there is a position for it. We pierce the retina, pierce the choroid, and finally tuck into the sclera. So once it is positioned well, again the engineers tell us whether it is positioned well, 5 degrees angle to the right, 5 degrees angle to the left, and all those things. And then you can see there's the cutoplast, that's the pericardial tissue, which is placed so that there should not be any conjunctival erosion. And finally, you can see the case was closed. So these are the few of the surgical snaps of my mentor, Dr. Robert Devaney, and how we performed the surgery. This was the second surgery we did it in North America. And is our implant team, and all courtesy and credits to this video presentation by Dr. Robert Devaney. And 2 weeks post implantation, actually now the real work starts. Is the patient has to undergo intensive visual rehabilitation. Here you can see it's almost 6 months the patient takes to learn what's the checkerboard, try to differentiate the light, the black, the white, the square, the edges, the circles, the triangles, and all those things has to be taught again with the new form. That's the checkerboard system. Also, they used it. So this the patient has to undergo an extensive training. So the benefits of this Argus 2, it helps in object detection, direction of motion, orientation and mobility, and of course, visual acuity of some form. So the 30 patients were conducted for the initial trial, and you can see the maximum best visual acuity was somewhere near 20 by 1000. So each implant used to cost around 144,000 US dollars, which comes to almost around 1 crore of rupees. So the features of the Argus 2, it has an upgradable hardware and software. It has a video processor with adjustable settings where you can do edge enhancement, contrast enhancement, And each electrode, that is around 60 electrodes, are individually programmable electrodes. So thanks to the man, the father of this Argus 2 is Mark Humayun. So what's the visual acuity? As I said, it's just 20 by 1000. So what's the cutoff for legal blindness in majority of the countries? It is 20 by 200. And what's normal vision? Is 20 by 20. And what's the field of view? It's only 20 degrees. And what's the natural vision we have? Is almost around 180 degree field of view. But the subretinal implants provide a still more lesser, that's around 15 degrees field of view. So remember, we need at least 1000 pixel display is required for near normal vision. That is, a large number of electrodes are actually required. So we are still a long way from being able to claim the restored vision. So what's the future of this? The zoom function will be incorporated into the software. They are trying to bring up with the color vision for the software. And Argus 3 is probably somewhere they're planning around 260 to 300 electrodes. So the next comes is the retinal implant Alpha, AMS Germany. So this is the second generation subretinal microphotodiode array retinal prosthesis developed by the Retina AG implant in Germany. It is designed to be implanted in the layer of degenerated photoreceptors, especially in the case of RP. And the Alpha IMS, that is the previous one, it consisted of around 1500 pixels, each containing a photodiode to sense the light sensitivity and light intensity. It measures around 3 mm into 3 mm into 70 micrometer array and given an input rate of around 5 to 7 hertz. So it sits on a polyimide foil which exits the choroid, sclera, supratemporally, and it connects to the power cable. So the internal coil receives the energy and communication. The external coil is attached to a battery pack and handheld controlled unit. I'll come to it. So see here, this you can see, this is the cable which passes through. So this is the retroauricular area where the incision is made, and it has to be passed in the subperiosteal area, make a hole in the temporal bone, and then try to trick it inside into the eye. So here you can see, this is after exposed, this is subcutaneously into the retroauricular space, and then you have to enter the orbit through the orbital rim, and then into the sclera, transscleral, transchoroidal, and subretinal. So this is the subretinal implant. So let me show you this. The Alpha AMS is the latest version with the improved lifespan, and it contains of around 1600 as compared to the IMS which had 1500. And this is a slightly larger, a 4 mm into 3.5 mm into 70 micrometer chip. So this was the first published paper on the about I've dreamed in color for the first time in 20 years. The patient with the retinitis pigmentosa, a blind British man can see. That's what. So let me come into it. I think I'll be showing it a little later about how it is made. So here you can see it's a wafer thin 3 mm square chip packed with 1500 light sensors implanted in the back of the eye. It takes around 10 hours of operation, and the ultrafine cable runs through the magnetic coil under the skin in the retroauricular space, and then it is pierced into the transscleral, transchoroidal, and then putting it in the subretinal area. So the results from this, it's around 25 out of 29, and the best visual acuity was around 20 by 546. So another system kind of retinal process is the photovoltaic retinal implant. That's the Bionic Prima Bionic Vision. So this is basically developed by Pixium Vision in Paris, France. Basically, it's tried for the patients with age-related macular degeneration. So what happens in the photovoltaic retinal implant? That is Prima. So this is nothing but same you saw the Argus implant, right? So similarly like that, this has an extra what you call as a projector. So this projector projects on to the retina the pulsed infrared light onto the retina, right? So this subretinally implanted wireless photovoltaic array, it converts the pulsed light into pulsed electric current. And then, as you all know, again, it's the same thing. Pulsed electric current changes the extracellular ionic concentration, making these ionic channels to open. And finally, the action potential is generated and impulse is generated. And that is how it is gone to the brain. So the implant measures around 2 mm in width, 30 micrometer thick chip containing around 378 pixels, and the images are captured by the camera, are projected onto the retina using the infrared, that is 880 nanometer, to avoid photophobia and phototoxic effects. So this again was tried in 5 cases, and the best visual outcome they could get is 20 by 460 to 20 by 550. So here in this surgery, what they do is they make a small retinotomy at the edge of the RP atrophy, around 2.5 mm of retinotomy, and then they place this implant in this in the subretinal area, and then they try to put the PFCL to stabilize. They use the IOCT to make sure whether the implant is properly situated, and then they use the silicone oil or the gas. So coming to the next is Epiret 3. So how is it different from the other two which I described? So instead of having it here outside near the transscleral area or outside in the supratemporal part of the sclera, so they tried removing the lens. If the patient is having a cataract, you have to remove the cataract. If the patient is having an intraocular lens, you have to remove the intraocular lens. And this chip is placed in the bag. And then trans-equatorial, they make 2 punctures so that these wires, you can see here, this wire is taken up here, and then same, the microelectrode array is fixed here with a retinal tag. So here you have this, the glasses, which is have the transmitter coil. So from this glasses, the rays fall on to this unit, and from there through the wire, it passes on to the retina, and then the microelectrodes get stimulated. So here the only disadvantage is the 11 mm sclerocorneal tunnel is made, and the IOL or the lens, whatever is there, has to be removed. We don't have much progress about this study. And the another thing is the Boston retinal implant. The Boston retinal implant devised by the Boston retinal implant project based in Boston. The human trials have not been done yet, is just because they are waiting for the engineering to develop, the technological engineering to develop, so that they can try to match the near normal vision at least. So that's they are doing a lot of research about the Boston retinal implant. And then we have what is called as the Bionic Vision Australia. So how it works, it similar way, it captures the image like the Oakley glass, what you have, a normal glass. And I'll see if I have this. Yeah. So here you can see the Bionic Vision Australia currently developing. I first told about the subretinal, that is alpha AMS, where they place it subretinally. But here, instead of going into the subretinal area, they place it in the suprachoroidal area. So it's a 24-channel prototype with 20 stimulating electrodes was implanted in the 3 volunteers as a phase 1 clinical trial. And 24-channel implant contained 33,600 micrometer platinum stimulating microelectrodes. And here you can see, this is the percutaneous connector, right? So this is fixed in the retroauricular area. So the intraocular electrode array of the suprachoroidal device and the entire device, it's showing this is the intraocular array, which is then carried out through the subperiod. I'll be showing that how that part of the surgery is done. So this is something I like to compare with the Iron Man, what is called as the arc reactor. You know, it is similar like this. You're just trying to disconnect and connect it behind the ear, and then you start seeing. So something like the Iron Man, you know, he uses the palladium core in these movies so that he can survive, he can live, and all those things. So it's similar to that. Here you can see how it is situated in the retroauricular space, and this is the percutaneous connector through which the video processed unit, or where the implants get generated, or they get stimulated, or they get amplified, they try to pass on through this, and they try to get conducted inside into the eye. So this is how it is placed in the suprachoroidal area. This is the OCT picture showing how it is placed in the suprachoroidal area. So the largest result is only around 3 patients they have done, and the best vision they could get is around 20 by 8,000, and the patient was able to see the landlord C chart as well. So before going to the challenges, I would like to show how this implant is working. It's connected. So this is what I was mentioning, whether it is suprachoroidal implant or whether it's a, are you able to see this screen? No, I think I'll have to stop it. Sorry.
Yes, sir, we lost the slide share.
No, I'll just do it. You're able to see now?
Yes, sir.
Yeah. So this is how I told. So this is the retroauricular connector, right? So from where it runs, and then percutaneously the subperiosteal space, you have to run it and then make an entry into slightly below the zygomaticofrontal suture or the orbitomargolaris, and here you have to pierce it inside. So let me show these surgical steps. So here, see how you take this incision in the retroauricular area, and then you fix it with a otologic drill. You need to make it, and the clamp you need to fix it onto the bone, and then you have to make an opening here in the lateral orbital margin, open it up, open the subperiosteal space, and then here you can see you use this trocar, to push it from the retroauricular area, and you need to bring it out through this lateral orbital rim area. And then you can see in the lateral area, 2 holes are made in the temporal bone. That is the L-shaped drilled canal, what they call it, through which it enters into the orbit. And these are the silicon tubes which are used. So here what they do is they first pass the silicon tube, they take it out. So from here they implant this connector. So once the connector is brought out through this, again the holes is made in this, into this bone, and then it is pierced through this, and then it you need to make a peritomy. You need to make the cutting of the lateral rectus muscle. You need to cut it, invert the eyeball, and then 9 to 10 mm away from the limbus. Here you can see 9 to 10 mm away from the limbus. You need to make a scleral flap, and from there you expose the choroid. In alpha AMS, you place it, you pierce the choroid and go subretinally. So once you go subretinally, you need to use the indirect ophthalmoscopy to see whether it is passed in the subretinal area or not. But here it is pretty similar what I showed about the Bionic Vision Australia, but the only thing is they don't pierce the choroid, but they make it place on the choroid. They don't pierce it and place subretinal. It's a suprachoroidal implant. And once that is done, a Dacron patch is put up on the sclera to cover it, and the peritomy is closed. And here you saw it similar to this. This is how the implant looks in the subretinal area. This is of alpha AMS, and this is how it looks on the OCT. And this has a microelectrode array which tries to stimulate the cells around this here, and it is pretty much similar to what I explained earlier. So coming to the challenges we see. So the challenges we see in this is, despite there is numerous advances in this retinal prosthetic device, understanding, design, and implementation, there are certain questions which needs to be answered. The most important is we still do not know how these retina get affected in the long term by these degenerative changes. We have lack of knowledge on that. Although the variable RGCs and the middle layer neurons, such as I explained about the bipolar, amacrine, all those things, the remaining photoreceptor, after the photoreceptor atrophy happens, the clinical vision loss occurs. It is difficult to quantify the viability to know who among the implant candidates actually have the good visual recovery. So once I put an implant, and then it should not be a futile exercise. So still we do not know who are the best suited, although they are in the late stage of RP or Prima, we use it for age-related macular degeneration, but we still do not have the perfect answer that who will be best suited for these implants. Since most of these affected individuals suffer from the progressive diseases, the long-term viability of these retinal intersurface is uncertain. That means when you place it in the epiretinal area, so what happens to the distance between the implant and to the ILM? What happens to that interface? Whether it gets fibrosed, whether it gets displaced, it's still the long-term studies are required to prove that. And most importantly, we keep on artificially stimulating it with the electric current. So the effects of chronic stimulation, when we keep on stimulating on the retina at the different levels, are still unknown. It is something like we keep on eating each and every time, and we keep on insulting our beta cells, and that is how the claim that the diabetes keeps happening pretty early. So we still do not know how this chronic stimulation of these artificial electric impulses behaves on the retina. And the other most important challenge is the technological advances. Although we have seen around 60 microelectrodes or some different, but we have not been able to achieve the near normal vision at all. So that remains a bigger challenge, because we need more number of electrodes in that small space. So how to do that is definitely an engineering challenge. So what is the future direction? The best visual acuity estimates for the implant subject have not even approached the threshold legal blindness. The best we have seen is 20/400, 20/500, that too in very few patients, which is not replicable in almost all the patients who are suffering from retinitis pigmentosa or age-related macular degeneration. The prospect of giving, of course, the important part here, what we need to consider is the prospect of giving patients suffering from outer retinal disease enough visual function to be useful in these basic function, while hoping for more dramatic outcomes, which we are expecting to come in one or the other future days. So the multiple devices are still under development. Rapid advancement in the chip technology is happening, which probably might be fruitful, and we just have to wait for the time. So these are the various other implants which I was explaining. I explained about the Argus 2. We have the Alpha IMS. Now the recent one is the Alpha AMS. I explained about the Prima vision, the Epirate vision, and the intelligent retinal implant system is still, it's working around 49 electrodes. And I explained about the suprachoroidal retinal prosthesis, which has around 33 electrodes. So like this, the various the projects are still going on, and hopefully with the more and more advancement in the technology and the engineering techniques, we should be able to reach the near normal vision very soon. So these are my references. And I would like to acknowledge one of my mentor, Dr. Robert Devaney, Dr. Waiching Lam, and the team from Second Sight, and my colleague, Dr. Giriraj Vibhute, who helped me in this making this presentation. And thank you very much for this patient listening. And Rolika, so who is the focused man behind the iFocus? A question to you.
To me.
Yeah.
One and only one.
It's Dr. Santosh Honavar, who is the focused man behind this iFocus. And of course, I would like to thank the teacher of teachers. And I would like to, I always keep saying Dr. Lalit Verma is one of the Bhishma Pitama of the AIOS. He's been a wonderful teacher, Dr. Dinesh sir, and the whole team of CFS, including Santosh sir, Rolika, Shefali. You have done a commendable job. 60 programs of retina itself is just short. I think it must be a Guinness record, as I said in one of the lectures. And I should also appreciate Lalit sir for having patiently listening to most of these talks. Though I was the moderator, I pardon sir. I please excuse myself that I couldn't attend few of the lectures, but I should really be thankful to all of you who have been so patient in sharing the knowledge and discussing with most of the eminent in the field of the different subspecialties. And it's really a wonderful program for the postgraduate, especially when you have it on the YouTube. They can just at 11 o'clock, 12 o'clock, or 1 o'clock in the midnight, whenever you feel bored or you don't understand, you just need to look into it and try to find it out. I think it's a wonderful plan you people have made. Hats off to you also. Thank you very much.
Thanks, Shrinivas. You see, all the retina surgeons, you see, do complex retinal surgeries of, macular surgery and PVRs, diabetics. And today you have gone, shown such complex surgeries and topic, and explained very, very nicely. Believe me, I heard each bit of it. Honestly, most of it went supra, but but some concepts definitely ignited some feeling that like you said, there is a future. There is a future. At least this biomedical marvel, I should call, has generated some hope. And US FDA, therefore, you see, 9 years back, more than 9 years back, February of 2013, ultimately approved this for these blind patients of retinitis pigmentosa. You see, it's a huge technical advance. You see, we talk of retinal surgery, but they're talking of tucking this retina, tucking this implant from the retina to the choroid to the sclera, and still, I heard this interview of this patient, Shrinivas, visited American Academy, where this patient was moving of his own. The first patient who was done. And let's have some couple of, I think there are some chat box questions. Rolika, will you read? Okay.
Sure.
One is, you see, one is, I think this being a vaccipellar in the RP disc, is it a healthy sign? No, I think vaccipellar means the disc is getting, atrophic. Shrinivas, you would like to answer
Yes,
something?
sir. Definitely, sir. The most important thing what we learned in our school days also in our postgraduate or graduate, the three triad. That is the vaccipellar of the disc, the bony specules, and the arterial attenuation. And still, it definitely holds good. And the second question is why vitrectomy in the Argus 2? A good question, because we need to go inside, right? So with the vitreous inside, you cannot penetrate that wire cable. In spite of doing a vitrectomy, you might be having a twist in the cable. When we were observing, when we were doing it on our patient in the University Health Network, Toronto Western Hospital, a small twist in the cable impedes the electronic impulses. So it has to be perfectly designed so that it has to sit for the way it has been designed, and for which the vitreous will definitely be a disturbance. And in case if you try to do it in the intact vitreous, definitely it will pull the vitreous and cause the retinal detachment.
So the thing is, any implantation you do on the retina without vitrectomy will lead to so many iatrogenic complications, the whole purpose will get defeated. So whenever you enter vitreous and want to do something in the vitreous or anything, first job is to do vitrectomy and peel off the hyaloid. These are two steps, I think, common to all VR procedures. And this is a very complicated surgery, epinephrine implant or subretinal implant. So entire vitreous has to be taken out and hyaloid has to be peeled as he has shown. No, Shrinivas?
Yes, sir. Very true. And the next question is, will there be any metal reaction on the retina, sir, or the rejection? A very good question. So first of all, I think I should also mention that, as I said, we have to be very careful while inducing a PVD or while peeling an epiretinal membrane, because we cannot afford to have any breaks. Because if we have a break, we cannot use the laser. The laser disturbs or destroys the electronic circuit. So we have to be very careful in performing any of these vitreoretinal surgeries, especially when it's a epiretinal implant where we try to tuck it. And few cases have developed a suprachoroidal hemorrhage or the retinal hemorrhage because you pierce through the vascularized choroid. So definitely there are chances that the bleeding might happen. But most of these authors have said that over the time, the suprachoroidal hemorrhage has come down and it has resolved pretty much well. Regarding the metal reaction, no, there is no metal put it inside. It's the silicon tip. It's the, as I said, it's the microelectrode photodiode arrays. It's all basically made up of the silicon. So we use the silicon oil, we use the silicon bands, we use the silicon tubes, the AGV valves, all are made up of the silicon material. Of course, what you're talking probably might be extraocular, what you're talking about the metal, but it's not the intraocular where we place these metals. It's extraocular. So I have not come across any studies or any authors where we keep discussing whenever I go to these ASRS meetings where there is a reaction to these metals because they are placed on the extraocular side. And if when I explained about this alpha AMS or IMS where the retroauricular where they try to do it, in fact the ceramic casing, the electronic case, they try to put it in the retroauricular area where they use the autologic drill to make a bed for it. They make a 2x2 or the 3x3 bed. On that bed, that implant is placed. And then it is patched on with a Dacron mesh or anything. So It's very far away from it, but it is sitting on the bone. Especially when I say about the alpha AMS, that's the Germany implant, what I was talking about. So,
Srinivas, how many people are involved in this surgery, where you start surgery from the retroauricular?
Sir, in that alpha AMS, I think 30 patients were undergoing that the thing.
No, during surgery, how many people, surgeons involved?
It will be, sir, I don't have much experience about the alpha AMS or IMS because that has not been tried very well, and it's still not the FDA approved, and correct me if I'm wrong. And so I don't have, but for the epiretinal implant, it's just the surgeon and the co-surgeon for it. Of course, there are the surrounding, you have 4 to 5 engineers who will be standing beside you. They have those multiple wireless connectors. As I showed in that, when you have this Oakley glass, you have the electromagnetic coil. So from there, it goes inside wirelessly. That is through the radio frequency waves, or what we call as the Bluetooth. So from there, the rays goes inside the eye. That stimulates these microelectrodes, and the electric currents get generated. There will be a disturbance in the electronic ionic circulation. Because of this, the voltage gated channel or the independent gated channels, they open up, and then these ionic channels move inside, and that's how the action potential and the impulses get generated.
So tell me honestly, Shrinivas, what was your first reaction once you assisted this? What was your, as soon as surgery finished, successful implantation done in Toronto, what was your, as a surgeon, reaction? Hooray, or what the successful done?
Sir, I would like to call it in during any fellowship life, when you come across these kind of surgeries, I would like to call it as a dream come true, sir. Because these are not performed very regularly, very routinely everywhere. And suddenly it was decided that, yes, we have to, although the course was going on with Rob Deveni and I was the fellow under him, there was a rotation. So I was a fellow under him. And the whole team of second sight were there. They tried to educate. It's not just about the implantation. There's more of engineering in this. So,
and did you talk to the patient post-operatively after few
yes,
weeks?
Sir. After 3 months, we discussed about that patient Audrey, which I mentioned about. So we did discuss, and the best part to me was I was in an apron, and she had, this is why. Oh, Dr. Joshi. She recognized that, although she could not try to see the color image or anything. But definitely she saw me walking, and probably because of my physique or something, she identified me, and she said, oh, Dr. Joshi is here. So, the patient who was not able to see, who was walking into our chambers each and every time, we did so many pre-op checkups on her. And every time she used to ask who is the person who is examining, or she used to say, okay, only by the auditory signal, she used to say, this is the fellow or this is the doctor. But when she saw it, I purposefully did not speak to her. I just stood beside her. And when she recognized me, I think that was really, the wonderful thing which I came across.
And did you have an impulse that similar thing we should do it in India? Because there's so many patients of RP or, ARMD in India who are, blind. And they keep asking because you see, once they Google or read about this, there are innumerable number of questions in their mind. And honestly speaking, we tell them, a lot of research is happening, and one day it will happen. So, what is your take, and what did you feel that can this be translated here, and why? Where are we now, and why are we so behind?
Sir, to be very frank with you, after coming back from 2014, I was very much behind in bringing this technology to India. Yeah. So I was behind second sight that why don't you put up a center in India? The closest center they had was in Europe. It's not just about the implantation and forgetting it all. It's basically the whole team has to be there, because it's more of engineering. The doctors are there only for 2 hours or 3 hours or maximum 10 hours in that, all those invasive surgery which I was telling about. But the most important is there has to be a team. Their team has to be there. And secondly, I think what I hear from second sight directly from the vice president of the second sight company, when Dr. Mark Humayun introduced me to him, is the DCGI asked for the 3 implant trial. So each implant cost around 1 crore rupees, around 144,000 or 150,000 US dollars. So the question was, who is going to sponsor those 3 clinical trials? And secondly, to put it up, the second site asked for these many patients to be there, because they come all the way from there till here. they train, they have to have an office, and all those things has to be there. So they also need to work out their the return of investment, all those things. So they couldn't establish a center here in Asia. Of course,
Srinivas, the manpower, there's no issue. Engineers, there's no issue. Doctors, there's no issue. Sponsorship may be an issue because sponsorship is a big,
to be very
big
frank
issue.
with you, most of these cases are funded.
Yeah.
Because when the patient spends 1 crore rupees and he is not sure that whether he is going to get vision, by in spite of giving 1 crore is just the cost of the implant. You need to add all other costs for that. Say maximum if it is, so spending 1.5 crore rupees, and if the patient is not happy with the vision, that's
so each of these industrialists, we have so many industrialists. One industrialist two by Mukesh Ambani, one by Adani. So they can actually sponsor. That's not 1 or 1.5 CR for them is hardly anything. What I'm trying to say is there has to be a interest group and sufficient interest generated, manpower, as you rightly said, biomedical engineers, all this team. And then I am hoping that Shrinivas one day will, lead this team and bring this dream into a reality.
So it needs the support of everyone, sir.
Yeah.
Because they asked at least 10 surgeries in particular month, in particular span. So 10 surgeries doing in a particular span. I think you only should meet Ambani and introduce us to Ambani or Adani and try to see how we can.
I will try. I'm telling you, I'm very serious. I will try. The day I catch hold of one of these Ambani or Adani, I am going to catch him. Because I am going to emotionally blackmail, because you see 1.5 CR is nothing. Yeah? They should 10 times they can easily spend. Because if we have something like Reliance Artificial Retina Center, it will be a great achievement. In any case, Rolika, any other questions from the
and another question from Sohini I would like to answer. In case there are any metal which are introduced inside, then they use this polyimide coating on that metal so that there will be no metal reaction inside. So this polyimide coating also has been used in some of these implants to prevent these metal reaction either extraocularly or intraocularly.
Right.
Rolika, any other questions from?
Yes, so there's a question that does presence of any other implant, like a cochlear implant, does it preclude the implantation?
Suppose patient has a cochlear implant, unfortunately, he is deaf also.
The VSLI design, if you see the VSLI design, that is where the cochlear implant, from this only they try to use this. But I'm not very sure, to be very frank with you, whether these signals are going to impede that signal. But since the cochlear implant is going to be deep inside the ear, and these epiretinal implants is just in the front of the eyes and through the radio frequency waves, I don't think that should be a problem. But to be honest, I don't know the answer if when there is a combined cochlear implant with these artificial, because in any of these cases, they have not mentioned where the patient has a cochlear implant who also has this.
I don't think so. They should be interfering, honestly, because they're all focused light or this thing. I don't think so. It will be too interfering in that. So,
and I think the subset is also very similar.
Yeah. The other thing is, honestly, suppose you see, we have a lot of Indian patients who can afford 1 or 1.5 CR. So what should we tell our Indian patients, that should they go to California, Germany, or Australia, or whatever? Should they or should they not?
Sir, I had one patient who was very rich, and he said he can go. But the problem here is it's not just a one-time journey, sir. They have to stay there for so many months. They have to, for any small defect, flying back all the way for 20 hours or 16 hours just to see what happened, what went wrong, is really a cumbersome journey. In fact, I heard that they started in the Dubai also, but unfortunately the surgeon went back to US. So if I'm not wrong, they have discontinued in Dubai. That was the nearest center where we could have sent our patient. So since it was,
I think that means the whole world is waiting for some form vision to return. Like you said, you said that patient of yours in Toronto, she could identify the green, apron or gown you are wearing. But obviously, form sense does not happen. And like you said, 20 by 1000, 20 by 900. But there is a hope. There is a hope, because whenever there is a hope, there will always be be expectations from the public. So let's not kill the hope of the patient. Let's not kill the hope of the patient.
Yeah.
We should.
In fact, Singapore team is also trying to come up. They are also doing research. Australia team. I'm sure that many other countries in Asia is also behind these trials, but none of these actually have entered the human clinical trial. Probably they might be still on the animal models, and we are expecting soon it to be a human clinical trial, and we are all waiting one day where it can be approved by all the countries, and we can have the near normal restored vision. We are waiting for that day, sir.
Yeah. Same for me also. So Rolika, any other question we have?
Yes, sir. So what is the lifespan of these implants?
To be very frank with you, still they don't have any answer, but most of these implants are what they have installed. Many of them are pretty much working well. I can tell most experience about the Argus 2 because that's the only first commercially available implant. So most of it are really doing well, because when I had a talk with my mentor, Dr. Robert Deveni, he said he has done nearly around 10 implants by now in North America. So if they have done 10 implants, then hopefully they should all be doing good. But since the 2 years, there was no connect with most of them because of the COVID. But when I go this time, I will definitely talk to many of these mentors and ask them what is the long-term, kind of things.
Do you know of any redos in such surgeries?
Yes, sir. So there are certain cases where the implant had shifted, so they had to remove the tag, they have to replace it and tuck it. There were certain cases where there was retinal detachment, and again the retinal detachment surgery was done. The silicone oil was put in, and the silicone oil was removed again. And in other implants, we have what we have seen through the literature. Some of them have even explanted also because of various reasons. So the redo also is an important thing to be kept in mind, because it might happen. But the safest, what I see here, is the epiretinal implant. In fact, I am also reading about the nano retina, which they are trying to just put a chip on the retina and trying to bring, but we don't have any clarity much on the nano retina yet. But if it comes with a good vision, then I think that will be the game changer. So it's still very ambiguous. There's no still straightforward answers to most of these questions, but definitely step by step things are evolving for more and more betterment of the for these patients of RP and ARP.
Right, sir.
So I think time is but let me conclude this by saying that what Shrinivas has shown today, this lecture, I think should be viewed by each and every budding surgeon, because today bionic eye is a reality. It's not a myth, because FDA approved nearly 9 years back, Shrinivas, and I heard a couple of interviews on YouTube also that patients jo emotional answers they are actually too good. And what I was reading was 80% of these patients find some improvement. What some is there, obviously you can't translate into channels. Hope in Indian patients is very, very high. You see, they spend 1 crore, they want 6/5 vision. That cannot happen. We should be very, very, once you counsel such patients, it has to be adaptation also post-operative. And what literature says, 40% say their lifestyle is improved in a significant way. So today, bionic eye is definitely reality, but as Shrinivas said, a lot of research is going on, a lot of development is there. But believe me, it's no longer a myth. Even blind patients. Only thing is there should be some PL, as he said. Some neurons in the retina should be there, which can translate or transmit this impulse via the optic nerve to the visual cortex. Then only some hope is there. But definitely, you see, like I tell all Indian patients who come to me, sir, wo paper mein padha tha, whatever. I tell them, hope is alive. And if not during my lifetime, it definitely will happen. Because you see, Mark Humayun, because Mark Humayun's grandmother was blind. That's what motivated Mark Humayun to take ophthalmology and biomedical engineering. And that's how I think he became the father of, prosthesis in Argus 2. So great job done, Shrinivas. And
Thank you,
believe
sir.
me, you have enlightened a huge bunch of retina people, including me, that we are so much, enthused by listening to your talk. And I do not think, honestly, Santosh, anybody has such rich material on artificial retina in our country, at least. So thanks once again.
Thank you, Santosh sir, for bringing it up, and thank you, Lalit sir, for your Ashirwad.
So I'd just like to conclude. You see, 7 months of retina. I think we started in the month of May, Rolika? November. Sir,
I
remember.
Sir, now the TRP is much better than IPL now.
See, I'm not watching today's match because I had this interesting talk today, and I said no way I can miss. Believe me, I canceled 2 of my engagements today just for Shrinivas because I wanted this topic definitely to be heard. Not because it was the last topic, but because this topic was such. Even though it may have been third, I would definitely be there for Shrinivas' talk.
Thank you.
And 60 talks, as Rolika was telling, you see, right from embryology, Santosh, right from embryology to all the procedures I have known in retina have been covered in the 60 talks. And hats off to all the speakers, and personal thanks on behalf of the iFocus team and on behalf of Santosh, Rolika, Shefali, Deepti, so many people who have been behind this show. I think we should congratulate Santosh for the excellent job done. And he has conceptualized this. Believe me, it's not an easy job. All of us keep talking, talking. And here is a man who has shown not only CFS, but the entire country, entire world, I would say, that how this thought process of educating everybody is definitely reality. And Srinivas, we have lakhs and lakhs of viewership, and that's what you see enthuses me as well as our chairman Mahipal in a big way, and he's very much motivated.
Focus, and I hope man, the audience, in the iFocus. That's why I said, sir, in my slide. One of and the I hope, most
I know, and I hope the audience also enjoyed all these lovely talks, 60 talks, and they will be definitely in our YouTube library. And audience must have enjoyed, as I enjoyed, chairing a lot of these talks, and really, Santosh learned quite a bit. So hats off to Santosh and the entire iFocus team, Rolika, Shefali, Deepti, Sohiri. So many of them are there who have made this, a wonderful experience for me. Thanks a lot.
Thank you so much. Thank you, Rolika. Yeah, sir, Rolika, we should really thank. She's always behind us. Always. Sir, are you ready? And all those things. Congratulations, wonderful job done, Rolika.
Sorry, sir.
No. That has to be there. Then only we'll be on our forefront and we'll keep running.
So thank you, Santosh. Thank you, everybody, and hope to see all of you in Mumbai, because I think we have 1 week break from June 1st and June 3rd, primarily for AIS. And after that, June 8th, I think we join back on exams and OSCE and other things in Retina.
Yeah. Yes, sir.
Thank you
so much. Last word, sir. Actually, I should say that when I was attending my PG programs, so once I heard about Dr. I'm not telling this because he has given me an opportunity, or I'm just telling it because he is sitting in front of me. But I would like to sincerely acknowledge that he has been really a role model to many of the younger ophthalmologists. I've been seeing him from 2008, where I started my post-graduation degree, and I'm still trying to learn from him and from Lalit sir and various other teachers. And he has been so passionate about this postgraduate education programs. And I don't think I should truly admit that I don't know any other person in India who has been so passionately trying to dip inside, like eating the teaching, drinking the teaching, and knowing the teaching to the postgraduates. I think we should really, all the youngsters and the postgraduates should be really thankful to you, sir. And once again, thanks to Lalit, sir. He has always been like a blessing man who keeps blessing like a Bhishma, who keeps things going on so smoothly. Thank you, everyone, for this wonderful opportunity. Thank you.
Thanks a lot.
Thank you so much, sir.
Good night.
Thank you, Shrinivas, for making many of the postgraduates think about artificial retina now. I'm sure that many of them are like, okay, we'll do it in future.
No, it's asked in the exam also.
Yeah.
The bionic eye, the different types of bionic eyes. I think they are being asked in the exams also in advanced paper.
Yes, sir. So we'll all meet you at AIOS. So iFocus doesn't stop, and we'll all be there, seeing you there in person. And the next lecture, as I mentioned, will be on June 8th. Thank you, everyone.
Bye-bye.
Thank you.
Good night.
Thank you.
Good night.
Good night.
Thanks.